As I mentioned, in any individual patient, if chemotherapy is given either before or after surgery, and there's no evidence, no clinical evidence of spread of the cancer on scans, then it's very difficult to impossible to know if the chemotherapy was beneficial in that individual patient. What do I mean by that? Well, if chemotherapy is given prior to surgery and 5 years later there's no evidence that the cancer has come back, is that because the chemotherapy successfully eradicated these microscopic cancer cells, or because the cancer had not spread in the first place and surgery alone would have been curative? And in fact, we don't know that in an individual patient, and that's why development of these types of strategies, what we call perioperative chemotherapy, sort of the umbrella term for neoadjuvant or adjuvant chemotherapy, that's why randomized clinical trials have been necessary to answer these questions in terms of whether or not this approach is beneficial. So this is a study that's called the SWOG 8710 study. SWOG stands for the Southwest Oncology Group. This is a study that was supported by the National Cancer Institute and run throughout the United States many years ago. And in this study, patients with muscle-invasive bladder cancer were randomized. And when I say randomized, I mean a statistician or computer determines which patients will receive which treatment arm. And in this randomized study, half of the patients were assigned to receive chemotherapy followed by surgery, and half of the patients were randomized to receive just surgery alone. Why is randomization necessary? Why can't we just say, let's let the physicians and the patients choose what they want? And of course, the limitation to that in the power of randomization and why randomization has actually been transformative in the world of clinical investigation is that it eliminates bias. And if we let physicians or patients choose which arm, then of course one might think that maybe the healthiest patients would opt to proceed with chemotherapy first because they would think that they could tolerate it better, or maybe the physicians feel the same way. And because the healthier patients are all going on this arm, and the outcomes at the end of the day look better in this arm, one would never know if that's because of a treatment effect or because it was just healthier patients. And randomization eliminates this bias. So this was a randomized study that was done, and here are the results of this study. And again, I'm showing a Kaplan-Meier curve here, and what the x-axis represents here is the months after that randomization to either chemotherapy followed by cystectomy or cystectomy alone. And here I'm showing two Kaplan-Meier curves representing the two different arms of the study, and it's a little bit hard to see here, but this line right here is a dashed line, and it represents cystectomy alone. And the top line is the arm that received chemotherapy followed by surgery, neoadjuvant chemotherapy. And you can see the distance between these lines at any point during follow-up. And what that represents is less patients having had their cancer return throughout the follow-up period compared to patients receiving surgery alone. In essence, a higher likelihood of the cancer being cured by giving chemotherapy prior to surgery. And it's really this study and another study that was done outside of the United States which have formed really the basis for the treatment recommendation of receiving chemotherapy prior to surgery for muscle-invasive bladder cancer. But that's only part of the story, of course, and chemotherapy, as we know, unfortunately is not without side effects. And I've listed some of the side effects in that particular study here, and the side effects that are commonly encountered with chemotherapy include suppression of the blood cells, temporary suppression of the bone marrow, the factory for the blood cells, including the white blood cells, which help fight infection, the red blood cells, which carry oxygen in the body. When those are low, that's called anemia, and people generally feel tired when they're anemic, and lowering of the platelets, which can increase the risk of bleeding. There can be mouth sores called mucositis, nausea or vomiting. These are some of the side effects that can occur with chemotherapy. Most of the side effects with chemotherapy, however, are temporary and completely reversible. And these side effects that I'm showing here, based on this study that was done in 2003, have actually been significantly reduced with some modern ways of administering chemotherapy, including the use of some supportive medicines to help prevent the white blood cells from dropping low. That being said, even with modern chemotherapy and modern supportive care, chemotherapy is certainly not without side effects, and that's why this is always a decision and discussion between patients and physicians about integrating chemotherapy and weighing the risks versus the benefits. But of course, as I showed, the overall benefit is supported by randomized clinical trials. So what about adjuvant chemotherapy? What about giving chemotherapy after surgery where we have this information regarding the surgical pathology, the extent of the cancer under the microscope, and perhaps we can make a more informed decision about integrating chemotherapy? And there are a couple of limitations to adjuvant chemotherapy. One limitation is that, again, as I mentioned, it's after surgery, and patients are just recovering from what is not an insignificant surgery and then starting chemotherapy, and it's a bit more difficult to tolerate in that setting. The second is, for a number of reasons which are really beyond the scope of this discussion, it's been much more difficult to prove the benefit of giving chemotherapy after surgery, probably based on some elements of the clinical trial designs that have been employed in this situation. So if you ask me my honest opinion, and if you ask bladder cancer doctors their opinion about this, it's a very controversial issue. But if you ask me my honest opinion, I do think that chemotherapy before surgery and chemotherapy after surgery likely offer similar benefit, but the evidence is much more robust in the neoadjuvant setting, giving it before surgery. There are these practical considerations with giving it prior to surgery, including being able to tolerate treatment better, and so that really has become the standard recommendation. So what's the takeaway? Well, the takeaway is for muscle-invasive bladder cancer, giving chemotherapy prior to removal of the bladder is really a standard of care, and we didn't talk about radiation-based approaches because that's a little bit outside of the scope of this discussion, but giving chemotherapy along with radiation is also a standard treatment for muscle-invasive bladder cancer. So that's the evidence. What happens in practice? And what I'm showing here is data based on a registry that encompasses about 70% of cancers in the United States. And this is a registry that's maintained by the American College of Surgeons and is used for multiple purposes, including research. And here you can see data from 2006 and data from 2010. And this is simply showing the proportion of patients during these 2 years, diagnosed during those 2 years, with muscle-invasive bladder cancer who underwent surgery alone, or who underwent surgery and received neoadjuvant therapy in the gray here, or who received adjuvant therapy in the green here. And you can see, despite this being a standard recommendation based on robust clinical trial evidence, only a small subset of patients received neoadjuvant chemotherapy, about 10% in 2006, and it's gone up a bit over the years. And in fact, an equal proportion of patients who had received adjuvant chemotherapy. And the logical question is, why is this? And there are a multitude of reasons why neoadjuvant chemotherapy is underutilized, including practice patterns, patient choice, physician choice, physician recommendation. And there is probably a subset of patients for whom neoadjuvant chemotherapy is ultimately beneficial who are not receiving treatment, and there are a number of ongoing efforts to make sure that there is dissemination of this practice, of this best practice. But there are also practical considerations. And one of those practical considerations is that bladder cancer occurs in an older patient population, and there are physiologic changes associated with aging, including physiologic changes associated with kidney function. In addition, other medical problems are more common. Comorbidities are more common as patients get older. And we know that there are some risks involved with chemotherapy, and those risks can be magnified in the setting of certain other medical problems. We try not to make decisions based on chronological age, but more so based on functional age. And as illustrated in this slide, there is a range of comorbidities experienced in patients in the same age. And so we really try not to focus on age. But in reality, there are these other medical problems to consider in weighing the risks versus benefits of treatment. And there are a subset of patients for whom the risks of chemotherapy might not sufficiently outweigh the benefits. And that's really a decision and a discussion that needs to take place between a patient and their treatment team, including their urologist and medical oncologist. Another challenge that I already mentioned is that we can't determine which patients have microscopic spread of their cancer, and thereby it's very difficult, if not impossible, to determine who benefits from this treatment approach the most, because we know that a subset of patients, in fact, a substantial subset of patients, are cured with surgery alone, and we certainly want to minimize giving chemotherapy to patients who ultimately don't need it and ultimately who don't benefit from it. And so this is really a prime opportunity to develop what we call biomarkers in the field. And what I mean by a biomarker is a measurable indicator of some state or condition. In other words, is there a test that can measure something about a bladder cancer that tells us whether or not that bladder cancer is more likely to respond favorably to chemotherapy, and so we could apply chemotherapy in a much more informed manner. And so there's been exciting ongoing work trying to define these biomarkers. And one of the ways this work has been done is based on what I mentioned before, that when chemotherapy is given prior to surgery, the response to the chemotherapy in that bladder tumor that is removed at the time of surgery can give us prognostic information. So what I'm showing here again are these Kaplan-Meier curves, but this time the curves are separated a little bit differently. This is from that original SWOG study that I already mentioned. And in this study, patients who had chemotherapy are here, patients who had chemotherapy are here, who had chemotherapy first, and then at the time of surgery, there was no evidence of cancer left in the bladder. That's what we call a pathologic complete response. In patients who had residual cancer in the bladder, whether or not they got chemotherapy or not, are on these lines. And you can see here that if there is no cancer left in the bladder at the time of surgery, well, not surprisingly, the likelihood of cure is substantially increased compared to when there is residual cancer in the bladder. And based on this information, what clinical investigators have done is to determine whether or not that could be predicted based on some features of the tumor at the time of the initial diagnosis. And specifically, much of the work has focused on mutations in specific genes located in the tumors. The genes that have proven to be most intriguing are genes that are called DNA damage response genes. These are the proteins in the cells that actually are there specifically to repair damage to the DNA. And one could imagine if those proteins are defective and can't repair DNA damage, and chemotherapy is given which induces DNA damage, then perhaps those cells would be exquisitely sensitive to killing by chemotherapy. And this is in fact what's seen based on small studies that have been done so far. And so these are the genes that were studied in this particular study. All of these are these DNA damage response genes, and this is another DNA damage response gene studied in another study. But the take-home message here is that if there's a mutation in one of these genes, then the likelihood that the cancer will be completely eradicated at the time that the bladder is removed is shown here, what we call the positive predictive value of this test. And you can see here that the positive predictive value ranges from about 80 to 100%, meaning that about 80 to 100% of patients with mutations in these genes in their primary tumor specimen who received chemotherapy before cystectomy had no evidence of cancer in the cystectomy specimen at the time of surgery. Now you might say, if there's no cancer in the bladder, then why is the bladder being removed in the first place? And of course, that's the perfect question. The challenge historically has been that we've been unable to determine if there's no cancer in the bladder until the bladder is removed. But with the development of these tests, there are some new strategies just being explored in clinical trials to determine whether or not, in the presence of these gene mutations, chemotherapy alone could be an effective curative treatment for bladder cancer. So what does the future look like in terms of new treatments for bladder cancer, for muscle-invasive bladder cancer? Well, part of this future outlook is what I just mentioned, trying to define biomarkers which might allow us to refine the use of neoadjuvant chemotherapy, not only to predict patients who might benefit the most from neoadjuvant chemotherapy followed by surgery, but perhaps even one day to define patients who can be treated with chemotherapy alone. The second part of the near future vision has to do with a new class of drugs that have been developed to treat bladder cancer, and those drugs are called immune checkpoint inhibitors, or PD-1 or PD-L1 inhibitors. And these treatments work very differently than chemotherapy. They work by allowing the body's immune system to recognize the cancer and mount an attack. And these drugs have already been approved for the treatment of metastatic bladder cancer that has definitively spread. And now several ongoing clinical trials are determining whether or not we should be using these treatments in the neoadjuvant and adjuvant setting, and perhaps increase further both the tolerability of the treatment or the proportion of patients who are cured with muscle-invasive bladder cancer.